Hello and welcome to our fourth Zoom session for Hearing Disorders 125. Today is, let's see, we are in the month of June. It would be June 24th, 2019. So here we go. What we're going to cover today is mostly and almost, inner ear disorders. Last week we kind of straddled between middle ear disorders. We finished up that one, and then we started on inner ear disorders. And let's kind of continue now where we stopped last time in our notes. So I'm going to share a screen here and go to the notes that we've got and pull these puppies up. So here we go. If you're looking here at the screen, you'll see, I'll make this just a tad larger. There we go. Inner ear disorders. And last week at the end of our Zoom session, or I'd say the last quarter of it anyway, we spent looking at the differences between sensory and neural. And in our corresponding PowerPoint in this particular unit, let's look at it quickly a second before we get into prenatal and all that stuff. But let's look here at our PowerPoint, and you will see in the PowerPoint here that there's lots and lots of shots that you might think, well, gosh, that's right out of anatomy. Yeah, it is. It's kind of like a review of anatomy. So when you're looking at slides number 1 through 2, you can see the basilar membrane getting wider and wider as you move to the apex of the cochlea. Okay? Remember, this is where the hair cells reside. Be sure you remember that. It's the scala media. All right, notice how it gets wider as you get toward the narrow apex of the cochlea. Look at this particular inner hair cells here, outer hair cells here. Be sure to keep this stuff in mind as we move forward. This is, again, review of a 120 anatomy. You're looking at the horizontal movement back and forth, oval window pushing in, round window bulging out, and you are looking at the corresponding vertical movement that takes place as a result. And that's because the helicotrema, la, 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 gets narrower there. So pressure builds up when the fluid is forced here because it gets squeezed into a narrow area. And therefore, there has to be some give. And that give is in the scala media, because the scala media here is the membranous labyrinth made of membranes. And so it's the only thing that can give, because the walls surrounding the cochlea, if you look at my cursor, are bone. So when you've got this horizontal movement of fluid pushing and it's squeezing into a narrow tunnel to get around through here, you're going to get a buildup of pressure. Follow my cursor here or here or here, whatever the case may be, depending if it's a low or high frequency sound. Showing it closer here. Be sure you look at this stuff and keep it. This is a verbal explanation of exactly what I was saying. This thing here always kind of gets in the way. Let me pull it out. There you go. So read this on your own. I can't spend the time now going through it, but I just want you to retain information that you've learned in earlier courses, because that will help you appreciate disorders of the inner ear. When you're going to talk about a disorder, you've got to know what's normal first. So I'll let you read that yourself. And this is showing you all kinds of traveling waves taking place because of just this one word, information. And you're looking at information going down, and you're looking at all these traveling wave ripples moving up and down the basilar membrane. And I'll show it to you again, moving up and down the basilar membrane, either here or here or here or here. Hundreds and thousands of traveling waves occurring all the time, depending on the sound. And look where the peaks are, more toward the apex if it's a low frequency sound, and more toward the base if it's a high. Again, just showing you the pictures. You've seen this in anatomy. You're looking at them now here. Hair cells, how small they really are. Hair cell on the gear, on the claw of the bug. There's a hair cell on one of the teeth of the gear held by the claw of the bug. Tiny. Normal. Remember, outer hair cells inner hair cells. Damage to outer, sensory. Damage to inner, neural. Okay? Again, sensory versus neural. That's what we covered last week in the beginning of our notes on inner ear disorders. Here's the top of an inner hair cell. Here's the top of an outer hair cell. Notice the array of stereocilia or hairs. Normal, damaged. Normal, damaged. And I would say this would be mostly sensory loss because the damage is mostly to the outer hair cells. And therefore, perfect hearing may look like this, and impaired hearing looks like this. Consider this slide a verbal analogy of these previous two slides. Whether you're talking in Shanghai or whether you're talking in Springfield, Missouri, the question or problem is the same. Passive traveling wave without outer hair cells. This would be an example of a low-frequency traveling wave, because the ripple or peak is near the apex, and an active traveling wave. Now you can see that two things have happened here. First, the wave got taller, and secondly, the wave got sharper. And remember from acoustics and anatomy that the sharpness of the traveling wave caused by the outer hair cells increases one's delta F. In other words, your ability to distinguish between frequencies close together. Your frequency resolution, all right, is worse here because this person has difficulty distinguishing the differences between the frequencies. This person has a finer toothed comb, if you know what I mean. And looking at the outer hair cells as they are embedded into the underside of the tectorial membrane, and if you just want to get a clear shot of that, just for fun, I'll make sure we know this. We're only 5-7 minutes in. But I want you to keep a grasp of these things. Here's the tectorial membrane, TM. And here's the hairs of the outer hair cells embedded into the underside of that membrane. Okay, so now let's just go to that slide we had. And look at it here. Okay, there you have it. You can see the indentations. They would have to tear off the tectorial membrane. This is the underside of the tectorial membrane, and these are in the embedded marks made by the stereocilia of the outer hair cells that are embedded in it. Nonetheless, the following takes place. This is the action of the outer hair cells pulling the tectorial membrane down so that the inner hairs can get bent or sheared. Okay? Think of the outer hair cells as the muscles of the cochlea. They are literally acting like an amplifier, enabling the inner hair cells to detect sounds below 50 dB. So if you've got damage to the outer hair cells, you have an inability to hear sounds softer than 50 dB. That would be sensory presbycusis. When the hearing loss gets worse, you necessarily have involvement of the inner hair cells, because outer hair cell pathology only gives you a moderate degree of loss. All right. So now let's get out of our notes for a second, out of our PowerPoint and back to our notes, and start to scroll down. So retain this knowledge, this paragraph here from last week's Zoom session and the discussion we've had so far today, in today's session. Be sure to have that down. Now, if we move to the middle of the page here, prenatal, and then you're going to see hereditary causes, and then you'll see below here prenatal, non-hereditary causes. Okay, now I'm never going to ask that people look at chromosomes and autosomes and blah, blah, blah. No. You can read this for fun. I'll never ask. This is never going to be on a quiz or exam, but it just gives you an idea of what genes and chromosomes are. Okay, you have 22 pairs of chromosomes. You have 50,000 to 100,000 genes along each of those chromosomes. You can have recessive problems. You can have dominant problems. In other words, hearing loss can be inherited from mom or dad or both. Recessive means mom and dad had it. Dominant means only mom or dad may have had it and the child inherited it. That's as much as we'll go there. Next. But you can also have prenatal or pre-birth, non-hereditary causes of sensory neural loss. Look what I write here. Prenatal, non-hereditary, prenatal causes of the Department of Redundancy Department. I think I have one too many prenatals in there. Anyway, mom may have had German measles while carrying the baby. Now, mom's symptoms may not have been much, but it will wreak havoc on the cochleas of the developing fetus inside mummy. Okay? Another non-hereditary but pre-birth cause of hearing loss, sensory neural loss, might be that mom had cytomegalovirus, a herpes virus that's often mild on the person who has it, but the developing fetus again has a 30% chance of being born with deafness or sensory neural hearing loss. Hereditary hearing loss is usually sensory neural. And hereditary hearing loss can be any configuration or shape. It can be cookie bite. Now, what the heck is cookie bite? Well, take a bite out of a cookie and look at the shape. Shaped like a U. Good hearing in the lows, worse in the mids, and better in the highs again. Could be, doesn't have to be. The shape of hereditary hearing loss can be any shape around. Okay, so we're kind of back to hereditary again, but you can have hereditary, non-hereditary pre-birth causes. You can have hereditary pre-birth causes. Look at Mondini syndrome. Mondini syndrome means that the cochlea doesn't have all 2.5 turns. And aside from Meniere's disease, which we'll cover next week, it's the only sensory neural loss that can actually fluctuate. Normally, only conductive loss will fluctuate in degree, or can. Sensory neural loss usually does not. Okay? You usually have it and it stays. Or you'll develop it and it'll slowly get worse and worse and worse, but it never gets better. Okay? Conductive hearing loss, you can improve things back to normal. Sensory neural, you can't. That's why you and I are in this program. You can only fit hearing aids. Okay? Sensory neural loss can get worse and worse, but it can never get better, except if you've got Meniere's, and except, which we'll talk about next week, or if you have Mondini. And now Mondini syndrome. Let's look at a picture of Mondini syndrome. Okay, let's find it here. See if I can see a picture of Mondini syndrome. I'm looking for it. Not there. Let's go home. Mondini, here, kitty, kitty, here's Mondini. Okay, here's a normal cochlea. A cross section. Let me get this stupid thing here out of the way. There. Now here's a cross section of a normal cochlea. Okay, so you can see scala vestibuli, scala tympani, and they call this CD. It means cochlear duct, otherwise known as scala media. Okay, where the hair cells are. Scala media. And notice again how it gets wider as you get toward the apex, all of that stuff. So this is a normal cochlea. All right, but here is a picture of someone with Mondini. It doesn't have all 2.5 turns. So this person will have quite a hearing loss. All right, and what's often taking place with Mondini is that Reissner's membrane. Now remember what Reissner's membrane is. See, this is why you've got to retain anatomy when you're talking about disorders. Reissner's membrane is the membrane that separates scala vestibuli from scala media. And let's just kind of look here for a second just to show you. Go home. Here, Reissner's membrane, separating scala media from scala vestibuli. In Mondini syndrome, this membrane is abnormally thin. And if the child bangs his head, or if the child is exposed to a lot of noise, this membrane may rupture. And when it ruptures, perilymph mixes with endolymph. The fluids that are opposite mix together. And so you no longer have that opposite charge like in a battery, because remember, that's what the cochlea does. It changes traveling waves into electrical energy. And if you don't have the differences among the fluid because this membrane has ruptured, you're going to have a worse hearing loss. And then the membrane will heal, and the fluids will become separate from each other again, and the hearing will get a little bit better. So fluctuating sensory neural loss is often associated, or can be associated, with Mondini syndrome. It's fairly rare. Mondini syndrome is not all that common. I know of only one person who has it. Okay, I remember testing his hearing at Toronto Sick Kids Hospital. I made a lucky guess as a brand new audiologist, and the ENT took a CAT scan and found out, yeah, it was a sensory, was Mondini, but I only detected it because you could see that the hearing loss had fluctuated across time. Older audiograms to audiograms done several months earlier to audiograms today, they showed changes, and so that's why it led me to suspect. I was a newbie grad out of school. Anyway, perinatal. That means during birth, and that's usually anoxia. Umbilical cord wrapped around the neck of the baby. Baby's not getting enough oxygen. Trauma to the head with forceps during delivery. That's nasty. But anoxia, lack of oxygen. Remember, the cochlea is a gas hog. It's like a Hummer. It drinks a lot of gas, okay? More so than vision, more so than smell, more so than touch, okay? So with lack of oxygen, hearing is the first sense to be affected. That would be a perinatal, or during birth. Peri means during, just like, or around, just like perimeter means around, okay? Peri means around birth. Postnatal, when hearing loss occurs after birth. Some examples of postnatal diseases that cause sensory neural loss would be meningitis, inflammation of the meninges. And remember what meninges is. The sac that surrounds the brain. Cerebral spinal fluid surrounds the brain. And it's held against the brain by way of the meninges, which is a small, or a sac that surrounds the brain, and it keeps that cerebral spinal fluid bathing the brain, okay? So inflammation of the meninges can cause total deafness. The labyrinths will fill with pus, then as infection heals, the labyrinth, meaning the cochlea, fills up itself with bone. It's gone. Usually total deafness. Another disease that may not cause total deafness but will be a pain in the ear will be measles. Measles can, a variety of it, rubeola, a 10-day variety of rubella, can cause more sensory neural loss than rubella for the person who gets it. So measles are of different types. You may have heard there's been outbreaks of measles lately, people not getting vaccines anymore. Anyway, mumps, don't feel you have to memorize all of this, but just realize that measles can cause sensory neural loss. Mumps, okay, jowls swelling, can cause unilateral sensory neural loss. Oddly enough, more associated with one-sided. Labyrinthitis. Itis, remember, infection, okay, or inflammation. Labyrinth is the cochlea. A viral labyrinthitis. That will cause dizziness, hearing loss, but it may return back to normal. Now, if you've got bacterial infection of the cochlea, then your cochlea is gone. The bacteria will eat the hair cells and they're gone. Viruses are very different from germs. Bacteria is germs. I'll stop sharing here and make sure we all realize this. Viruses are tiny. Germs are like cells. You'll see they'll have a nucleus. They'll look like a sunny side egg. Okay, the nucleus is the yolk, and all the other junk around is the white. And cells are like you can see them under a microscope quite clearly. And bacteria, are large, are germs. Now, germs and bacteria are the same thing, okay? Living cells. Viruses aren't. Viruses are tiny, 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 tiny little things, and they're shaped like the weirdest things, and they multiply like crazy. Viruses cause flus, viruses cause colds, and you can't take antibiotics for those, as you may know, okay? The only time antibiotics will help is if you have germs or bacteria. So bacteria, germs are fought by antibiotics. Viruses are not. So if you have a viral labyrinthitis, it's way better, though, than having a bacterial labyrinthitis, okay? Bacteria will deafen the ear, okay, which is rare. That labyrinthitis is fairly common. People have dizzy spells for a while. It'll go away, all right? So it's one of them things. It may leave you with some permanent sensory neural loss, but not usually. Usually the effect is more on balance, it seems. Anyway, let's look at ototoxicity. Ototoxicity. Now, if this thing will there we go. I can now move here. Ototoxicity. Oto, ear, toxic, poison. Now, put a star by this one. Aminoglycosides. Make sure you know how to spell it. All right? These are particular antibiotics. Not all antibiotics are aminoglycosides. Aminoglycosides happen to be one type of antibiotic that happens to be ototoxic. Sometimes fighting the disease is worth causing hearing loss because otherwise you might die. All right? Aminoglycosides always end in the suffix mycin, M-Y-C-I-N. So look at the examples on the page here. Neomycin, kanamycin, streptomycin, viomycin, gentamicin. All of these can cause permanent hair cell damage in either the vestibular system or cochlea or both. Okay? Gentamicin was often given for tuberculosis. People who had tuberculosis were treated at sanatoriums with gentamicin. Yep, it cured the tuberculosis, but they walked out deafer than doornails. Okay? Permanent. Quinine is another one. That was taken for malaria. All right? That often causes ringing in the ears and sensory neural loss. Ototoxicity is often first noticed for the high frequencies. Physicians who prescribe ototoxic meds often have time before the hearing loss can invade the speech frequencies. So remember, your hearing goes all the way out. I'll stop sharing. Remember this too, okay? Remember from anatomy, remember from acoustics. Your hearing range goes from 20 hertz to 20,000 hertz. It really hurts. By the time you're 10, you can't hear 20,000 anymore. By the time you're 15, you'll have trouble hearing 18. You know what I'm saying? So gradually the highs generally are cut off anyway. When you get to be 65, now you're invading the audiogram. You're hitting 8,000 hertz, 6,000 hertz, 4th. Okay? So always remember that presbycusis is actually an ongoing thing that takes place throughout your life. It's when you get to be 65-ish that it begins to invade the speech frequencies of the audiogram. So, ototoxicity may hasten that loss of the high frequencies, and doctors may know this. And an ENT giving an ototoxic drug for a good reason may recommend that a ultra-high frequency audiometry be done to detect how quickly the person's losing those really, really high frequencies, because that's what ototoxic drugs do. And then they'll begin to invade the speech frequencies, and the doctor will stop giving the drug if possible. So this is the idea here. Let's share screen. All right. There you go. Ototox, ultra-high frequency audiometry. Blah, 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 blah. Don't worry about these things here. 2 medications of exception to note. Put a star by this one too. Erythromycin, just because it ends with mycin, it is not ototoxic. Erythromycin is very commonly used antibiotic, sometimes even for outer ear canal infections. Okay? It's not an aminoglycoside. Aspirin. Elderly people take aspirin often for arthritis and as blood thinners to prevent a stroke. As a good HIS, you will take a case history. If your elderly client complains about tinnitus or ringing in the ears, you might say, what medications are you taking? If the person mentions aspirin, that's a reason. Aspirin causes tinnitus. It does not cause hearing loss, but it does cause tinnitus. And tinnitus is weird. Tinnitus, let me just describe quickly tinnitus here. It's a subjective sound. Only the listener hears it. A doctor can't put a stethoscope to the ear and hear it. Please remember, ringing in the ears is subjective. It's not a real sound. Now, otoacoustic emissions, which we'll cover a little bit next week, they are an objective sound. Okay? It's actually coming out of the ear. And otoacoustic emissions, if you'll recall from anatomy, are a byproduct of the outer hair cells working their tails off. All right? When you work hard, you sweat. That's a byproduct of working hard. A light bulb produces heat. That's a byproduct of the light bulb. Okay? But tinnitus isn't that. Tinnitus is caused by an imbalance of brain going and brain to cochlea going information. Very complicated, complex reasons why. You can't fix tinnitus. Okay, you can't. There's no magic pill, no medication, nada. All you can do is train the person to realize that tinnitus is more noticeable sometimes than it is other times. And when is it most noticeable? In dead quiet. When you're trying to sleep. So, cover it with a bit of noise. And if a person has tinnitus, he or she gets afraid because he or she doesn't know what it is. See, background ambient noise masks the tinnitus. And when you were young, you could hear normally. So the background ambient noise you heard masked any ringing in the ear that you might have. But when you get old, you can't hear as well, and so you can't pick up the background noise as well. And so that's why you hear your tinnitus more. It's all about psychological treatment as well, masking with background noise and getting the person to realize it's not dangerous. It's not a brain tumor. That's another thing you got to rule out though. If a person complains about tinnitus, that's a red flag, and you should refer to a physician so that the person can get what they call an ABR done, auditory brainstem response, and that's done by an audiologist or an MRI or whatever to rule out an eighth nerve tumor, because eighth nerve tumors are one cause of tinnitus. And if you can rule out that, then the tinnitus can just be considered a nuisance. I always say it's just like being stuck in traffic and you don't know what the problem is. So finally, you get out of the car and you knock on the door of a truck that's beside you because that person can see further. And you say, do you know what's going on? Yeah, there's an accident a mile up ahead, blah, blah, blah. Okay, then you get on your cell phone, call home, yeah, I'm going to be late. But right away, your anxiety's gone down. That's part of the treatment with tinnitus too, is to teach the person it's not a dangerous thing, it's just a pain in the ear. Anyway, enough about that. Let's go back to share screen here and talk about ototoxicity. And let's see if we've got a shot of ototoxicity. So I think we do. Further down in our PowerPoint here, here you go. Here's an audiogram associated with ototoxicity. Look at its high frequency hearing loss. Audiogram, read at the bottom, obtained from a patient with gentamicin ototoxicity. Note the symmetric, severe, high-frequency sensory neural loss. And here's, you've got normal hair cells, and now you've got ototoxicity. Ototoxicity, notice that it affects mainly the outer hair cells again. The outer hair cells are the princesses, the spoiled little princesses of the cochlea. They are the first to die with presbycusis. They're the first to die with noise-induced hearing loss, which is the second most common cause of hearing loss. And they're the first to die with ototoxicity. So now let's get to the main cause of sensory neural loss, presbycusis. There you go. Look at it carefully. Mostly due to outer hair cell loss, sensory as opposed to neural, fair to good speech discrimination. That's what the SD stands for, remember. Single syllable words are presented to the person at the person's most comfortable loudness level, remember? And that person is asked to repeat the words, and the words are not like, see the big black cat. And I'm going to stop sharing and make sure we understand this. This is a review from last week. The typical hearing test has 3 pieces, remember? Air conduction and bone conduction testing. Headphone, how do you hear the tones? Now the tones through the bone, how do you hear the tones? If you hear the tones better through the bone than through the ear, you have a conductive hearing loss because you have a hearing loss this way, but you don't this way, because you're bypassing the outer and middle ears, and when you do, your hearing's normal. That means you have an air-bone gap, conductive loss. However, if your hearing is bad this way, and it's similarly bad this way, then you know that the outer and middle ear have nothing to do with it. They're free of guilt. The problem is in the inner ear. Okay? So when I'm showing you an audiogram that looks like this, that's presbycusis. Look at air conduction for the right ear is the O's, air conduction for the left ear is the X's, the way you heard through headphones. So it's showing you better hearing in the lows, getting worse toward the highs. And then the greater than signs mean you stuck the mastoid thing. In this case, they put it behind the left ear. Okay, because greater than is the left ear, lesser than would be the right ear. Think of the patient facing you. Okay, when the patient faces you, his or her left ear is going this way. So look at the hearing, it got no better. It didn't, it stayed the same as air conduction. So you know the loss is in the cochlea. And then the speech discrimination, well, that's the second part of the hearing test. And speech discrimination, speech testing has 4 parts. Remember from last week? First, it's most comfortable loudness for hearing speech. Secondly, it's the softest that you could hear spondee words, which are 2-syllable words. Hardware, cupcake, armchair, ice cream. Words made from 2 little words. Say hardware, and you're at 50 decibels or something. Now you turn it down to 40. Say cupcake. Person can repeat it. Go down to 30. Say woodwork. You're not letting the person read your lips. And the softest that person can hear speech is called speech reception threshold, SRT. And then you go back to most comfortable loudness and you say, these words won't get any softer. Repeat these after me. And these are single syllable words. Say the word tree. Say the word nose. Say the word wood. Say the word cow. And you're testing the clarity of someone's hearing, and you're not getting softer. You're staying at their most comfortable loudness level. Well, in this person with speech with presbycusis may have fair to good speech discrimination, not bad, in quiet, no background noise. They'll do pretty good. 80% of the words they'll get, not bad, okay? And then we said the last part of a hearing test is the tympanogram, testing the middle ear function. Okay, anyway, typical presbycusis. Look what happens over age, okay? Gradually losing high frequencies. Just showing you pictures. Now here, remember performance index functions. Look at this. And you'll learn more about this in audiometry too, but I'm just going to give you a little bit of a gander at it. This is regarding speech discrimination, those single syllable words. What was the intensity level? And how did the person do in percent? So if you've got normal hearing, really soft, you do poorly. And when you're around 40 decibels, you're doing pretty good. But when you've got sensory neural loss, you never really get 100% because you got some hair cell damage, even at louder levels. Okay? Remember, the intensity level goes along the horizontal, and the vertical shows percent correct. Now, this one here might be of an eighth nerve tumor, which we'll talk about in a couple of weeks. Okay? Toward the end of the course. This person actually gets rollover, does worse as the words get louder, because the eighth nerve has a tumor and it's overloaded. Weird, huh? Anyway, speech discrimination and sensory neural loss. I think what I'm going to do is I'm going to go to the notes more first. Let's look at presbycusis. Let's just kind of look at our notes with presbycusis, and then we'll come back to the other. Here we go. By far the most common hearing loss, that's sensory neural, and of any hearing loss, begins at age 65. 30% of people over 65 have it. 50% of people over 75 have it. Put a star by that. That's a well-known statistic. You should always walk around with that in your back pocket. Obviously, it has to affect more than just the cochlea because the whole central auditory nervous system ages. The whole body's older. Ossicles, cochlear windows, oval and round windows, eighth nerve, and brain. Jurger, who coined the type A, type B, and type C tympanograms, you'll recall, Jurger is one of the popes of audiology. He's retired now, but he recommends fitting the very elderly, 85 plus, with only one hearing aid because they can't handle binaural input. Remember the word decussation from anatomy, crossover? Elderly that are very old, their whole nervous system is aged. They're often doing better monoraurally. It's a finding that he's published. Elderly cannot always handle binaural aided inputs. Now remember, this is only for the very elderly. The audiogram with presbycusis, usually mild to moderate, and that's what we showed you here, mild to moderate. So here we go. Look at the degrees. Mild to moderate, sloping, and no air-bone gap. Okay, so you know it's sensory neural when there's no air-bone gap. Air-bone gap, difference between the way they heard by air conduction versus bone conduction. So just looking at that. Okay, back to the notes. Type A tympanograms, normal tympanograms with the peak above normal room air pressure. Normal height of the tympanogram, that's static compliance. Acoustic reflexes are all kicking in. But remember, they'll be doing so at reduced sensation levels. In English, remember what its sensation level is. Always retain the information, okay? Sensation level is the difference between the presentation level and your threshold. So let's say your hearing, you can hear all the way down to 0. You'll have acoustic reflexes at around 100 dB. They'll kick in, even less, 85 to 100. Now pretend I walk in and I've got a 50 decibel sensory neural loss. Present the tone to me at 85 to 100, and I'll also probably have an acoustic reflex at the same level. But my sensation level is reduced because my thresholds are 50 and yours are normal. So yours might kick in at 85 to 100 dB sensation level. Mine are going to kick in at around 35 dB sensation level because I have a 50 dB hearing loss. You get it? So a common findings for presbycusis are type A tympanogram, mild to moderate sensory neural loss, present acoustic reflexes, Fair to decent speech discrimination or word recognition, same thing. Word recognition, speech discrimination, same thing. All right, good. Share screen and look at the notes. Because now we've got to look at 4 different types of presbycusis, and these were classified by a guy who lived in a van down by the river, and his name was Schucknecht. Schucknecht was a doctor, an ear, nose, and throat doctor, I believe, and what he did was he coined 4 classic types of presbycusis in cadavers. He had people who had died, but they had hearing loss and had audiograms that were done on them. So what he did was he tried to classify the type of audiogram the person had with presbycusis and what kind of hair cell damage the person had to match these things together. And he found the most common one was sensory presbycusis. Mild to moderate loss, worse hearing in the highs than in the lows, decent speech discrimination, fair to normal, like the audiogram I showed you. And what was their damage? Outer hair cell pathology. Outer hair cell pathology mainly. Mainly around the base of the cochlea. Look what's highlighted here on your screen. Mostly high frequencies. Then he found another type that was neural. And with here, what does the 8th nerve mainly attach to? What set of hair cells? The inner or the outer? It's the inners. The inners send all info to the brain. The outers take info from the brain to sharpen the traveling wave. So neural presbycusis was usually worse in degree, generally had a fairly flat tympanic audiogram, didn't slope as much, and the person usually had poor speech discrimination because a garbled set of information is getting to the brain because inner hair cell damage, inner hair cells are attached to the 8th cranial nerve. And the 8th cranial nerve, right where it meets the hair cells, that area is damaged. Okay, so the spiral ganglion of the 8th nerve where it meets the inner hair cells and the inner hair cells themselves, neural presbycusis. Usually the loss was worse. Stop sharing. Remember what I said last week too, though. You may get 2 people, both of them may have mild to moderate sensory neural loss. One has good speech discrimination, the other one has poor speech discrimination. ¿Qué pasa? What's the difference and why? It may be that the person with the decent speech discrimination has damage only to his or her outer hair cells. The person with the poor speech discrimination may have the mild to moderate loss caused by damage to both sets of hearing loss, of hair cells. Hereditary, who knows? Okay, so the hearing loss doesn't always have to be way worse with neural. Okay, it may be similar in degree, but is associated with poorer speech discrimination than sensory. Usually, however, it's worse in degree because outer hair cells usually die before inners. It's not always that outers die and then inners. It may be that both sets tend to die in some person. That person will be having poorer speech recognition. Okay? The third type that Schucknecht noted was called strial presbycusis, number 3. And that is caused by problems with blood supply to the cochlea, the stria vascularis. The hair cells are not getting as much oxygen and blood supply due to damage of that feeding function in the cochlea. Remember the stria vascularis. Let's look at it. Stria vascularis. Whoops. Share screen. And let's look at our PowerPoint. And go home. Look at the stria vascularis, right where my cursor is. The blood supply to the hair cells. If that's damaged, you're going to have damage to all frequencies of hair cells along from the base to the apex, and so the hearing loss will be flat. It'll have pretty fair speech discrimination, but a flatter configuration of sensory neural loss than sensory. Okay, fair to decent speech discrimination, and more common among women than men, because women tend to be slightly more susceptible to heart disease than men. Okay, so it's just one of them things. Read what it says. Fairly flat audiogram with fair speech discrimination. All right. Neural, poor speech discrimination, fairly flat audiogram with slightly worse hearing loss in the highs, and I would add slightly worse hearing loss in general, because outers tend to die before inners, and usually, not always, but usually, neural loss will be slightly worse than sensory, because inner hair cells are also involved. And then you had a fourth category, which was like a garbage can category, audiograms that didn't fit into any of the above. High frequency sensory neural loss. I lost an H in here. Okay. High frequency sensory neural loss, that's not explained by any of the above. So it could be less mobility in the basilar membrane, less mobility of the oval window. Some of the moving parts of the cochlea might be kind of seized up. Okay. A cochlear conductive or cochlear mechanical presbycusis. So there's your 4 general types of presbycusis. So not all presbycusis is exactly like this little picture is showing you here, as I'll go to. Okay, not all presbycusis is exactly like this. This is just showing you a generic, typical sensory presbycusis. Neural might be a little bit flatter. It usually is a little bit worse anyway. You think about someone who has 80 decibel hearing loss. Pretend these X's and O's are all around 80. You know that that person has not only outer hair cell damage, but also inners. They have to, because the most hearing loss that outer hair cell damage can cause is a mild to moderate loss, around 50. Okay? So if the hearing loss gets to be worse, inners have to be involved. And then if with a flatter loss that isn't so terribly bad, has decent speech recognition or speech discrimination, strial presbycusis caused by lack of blood and oxygen supply to the hair cells. And then you had cochlear conductive or cochlear mechanical presbycusis that's not explained by any of the above. Again, Schucknecht just looked at the hair cell damage in the dead person's cochlea and tried to associate the type of hair cell damage and stuff he found with the type of audiograms that the person had. And he came up with that classification of presbycusis. So here we go to our notes now for a second and look at gender effects of presbycusis. By Jerger again. Males tend to show a steeper sensory neural loss than women. They'll have better hearing, usually, not always, but in general. Better hearing in the lows, but worse in the highs. So the slope will be steeper due to noise-induced hearing loss combined with presbycusis, because more elderly males have worked in noisy factories. Okay, females will generally show a flatter sensory neural loss with poorer low frequency hearing but better highs, maybe due to heart and stroke disease in women. The stria vascularis is more affected, and that would mean that the women would have poorer low frequency hearing than males, but males will tend to have poorer high frequency hearing than females, because noise-induced hearing loss causes hearing loss only in the highs. And that's where we're going now. Okay, so read again. Get a kind of mental grip here as to why men generally, not always, but usually may show better hearing in the lows and worse in the highs. Worse in the highs because of a combination of presbycusis and noise-induced hearing loss, which causes only high-frequency hearing loss, but better hearing in the lows because the men may not be quite as susceptible to strial presbycusis as women. Okay, but these are generalizations. He was looking at hundreds of audiograms and came up with a general pattern. All right, Let's get to the second most common cause of sensory neural loss in the world. Noise-induced. Much worse in our loud society than in non-industrial places like Africa. Can result from brief exposure to sudden loud sounds, like acoustic trauma, or constant exposure to loud sounds. Again, internalize the difference here. One is a rifle shot too close to the ear, bang! And it caused, whoa, noise-induced loss, permanent. Unusual, but can happen. Or it can mean because the person was daily working at a sawmill, using chainsaws, and not wearing ear protection. That would be from constant exposure to loud sounds. Read our notes down further. Get to page 3. You can have either temporary threshold shift or permanent threshold shift. Temporary threshold shift, after you've been to a loud bar or a concert, your ears are ringing. Tinnitus. The hairs are blown down of your hair cells. Overnight, they'll stand up again. But if you keep walking over the grass, you'll wear a pathway, and now the blades are gone. Permanent threshold shift. You get it? That's why workers in noisy places, when they're being tested for noise-induced hearing loss, they're tested first thing in the morning, before their exposure to the noise. Permanent threshold shift due to noise. The sensory neural loss will be most pronounced at 4,000 hertz. 4,000 hertz. And tinnitus is the most common complaint. Remember these things. This is the earmarks, in quotes, of NIHL, noise-induced hearing loss. It can affect anyone exposed to loud sounds, but what are the limits? What is it? Put a star by this. You had it in acoustics, now you're getting it again, okay? 85 dBA. What the Sam Hill is that? 85 decibel sound pressure level, but taking into account that we don't hear the lows quite as loudly as the highs. Let's see if I have a picture of anything in the PowerPoints to kind of give that away. Not sure, but I might. Don't think so. Okay. Doesn't matter. I can easily explain it here. First, let's look at noise-induced loss. Here we go. Noise-induced hearing loss, the second most common cause of hearing loss in the world. The saddest thing is that it's preventable. When you're looking at noise-induced loss, there's the audiogram associated with it. Look at that. Good hearing in the lows, good hearing in the mids, and then a precipitous drop past 2,000 hertz. And when you're testing for noise-induced loss, you should always test the mid-frequencies. See these dotted lines? Because you want to find out what happened between 2,000 and 4,000. You got a big drop there. So what was 3? Anytime you have more than a 20 decibel difference between adjacent frequencies, you should check the mid-frequency. Anyway, so this person was tested at 3,000, 4,000, and 6. And you can see if you follow my cursor, there's the drop. It's like a mouse came in at night and took just a chomp out of a narrow, high-frequency region. And look at how the hearing gets better again at 8,000 hertz. Isn't that weird? The reason why is because of the ear canal resonance. Your ear canal resonance, the outer ear canal resonates, remember, with its own mass and stiffness. It's a quarter wave resonator. It's going to resonate with sound waves that are 4 times its length. And in acoustics and in anatomy, we did the math with that. And we came up with the fact that frequency equals speed of sound over wavelength. Wavelength equals speed of sound over frequency. Just like 5 equals 10 over 2 and 2 equals 10 over 5, same thing. All you're doing is a little formula. And you come up with the fact that the ear canal being about 1 inch long or 2.5 centimeters long is going to resonate with sounds that are about 3,000 to 4,000 hertz. Now, your ear canal is not made out of glass or steel. It's made out of flesh and bone, so that resonance is fudged or spread out a bit. And there's also something called the half-octave shift, and that's shown here. Most industrial noises are broadband. Okay, they involve a lot of frequencies. Read the next line. They're like white noise or pink noise. They're broad. External auditory meatus, ear canal resonance, creates a band pass noise centered at 3,000 hertz. Look, all the noise has to pass through this filter. Look, your best here, this natural resonance, if the noise is hitting that natural resonance, what's going to be emphasized in the noise? Here. And that's why the loss will mostly be here. But this half-octave shift means, and this is due to physiology, don't freak about this, just realize that the basilar membrane peak displacement tends to be greatest at a half an octave higher than the frequency of the stimulus. In just cochlear physiology, the peak of the traveling wave tends to occur about a half an octave higher than the frequency of the sound that created that traveling wave. Because of that, you're going to get this shifted up a half an octave. So if you take this, move it to the right a little bit, and flip it upside down, you got that. Okay? That's the main reason for the shape of noise-induced hearing loss. So the shape of the loss, even without a case history, can tell the experienced clinician, I'll bet you this was caused by noise. The very fact that it gets better again at 8,000 hertz hinges largely on the fact that this goes down. Okay? So you're taking this resonance, you're shifting it to the right a half an octave and flipping it upside down, thus giving you the shape of noise-induced hearing loss. And what causes noise-induced hearing loss? 85 dBA for 8 hours or more. Let me explain what dBA means, although you may recall this from acoustics. Remember in acoustics we talked about minimal audible field, minimal audible pressure? Remember we did that? What's the softest it takes to hear a 1,000 hertz tone at 1 meter distance from a speaker with 2 ears? Okay, we'll call that 0 dB SPL. Now let's play that same game at other frequencies. So now you're playing 2,000 hertz at 1 meter distance from a speaker with 2 ears, 4,000 hertz at 1 meter distance, and you'll notice that your hearing levels are curved. Okay, 0 may just be the softest it took to hear 1,000, but you needed more than that to hear 500, and even more to hear 250, and even more to hear 125. Remember that? Okay, and then you did the same thing with 1 ear under a headphone. We called that MAP. You had the same shape, but it was just 5 dB higher. And then we stomped our feet and we said MAP, the softest it took to hear in dB SPL, with all the tones, with 1 ear under a headphone. We said that is capital I, capital S, underline, bold-faced, italics, is 0 dB HL, the flat line across the audiogram. Well, dBA just takes into account that our hearing is uneven across the frequencies. We hear the mid to highs better than we hear the very lows. So noise-induced hearing loss measurements with a sound level meter include MAF. They're looking at the very shape, saying, hey, it's not fair to say that 125 hertz at 85 dB causes sensory neural loss, because we can't hear those frequencies as well. So that's all dBA means. It takes into account are uneven hearing across the frequencies. Enough on that. Share screen. Put a star by this because it's on the test. Okay? 85 dBA for 8 hours or more causes permanent noise-induced hearing loss. As the intensity goes up by 5, the allowed time gets cut in half. Some states say as the intensity goes up by 3, the time gets cut in half. But for the sake of this class, just know this. If you're exposed to 90 dBA, or SPL, but with that taken into account the curve, then you're allowed only 4 hours. And if it's 95, 2 hours. And if it's 100, 1 hour. So there's an interaction between the intensity and the time you're exposed to it. All right, the next parts of the notes concentrate on why does noise-induced loss get worse, especially at 4,000 hertz. Well, we covered some of that. Some say because of the acoustic reflexes. Nah, because why only at 4,000? Why is the loss not at 2,000? Okay, I know acoustic reflexes are stronger for low frequency, loud low frequency sounds, but that doesn't explain why the loss is only at 4. Some say that there's poorer blood supply to the 4,000 hertz hair cells. Some say the vector of the footplate Stapes footplate causes hydromechanical damage to these hair cells. In English, this just means as the footplate of the stapes pushes in and out of the oval window, the movement of fluid, like a backwater eddy of an oar in the water to swirl, the movement of fluid tends to irritate the 4,000 hair cells the most. The 4,000 hertz hair cells the most. Those are clutching at straws. I think the most elegant reason for the shape of noise-induced loss is what we described earlier, and that is the ear canal resonance and the half-octave shift. Therefore, you've got most sensory neural loss with noise-induced hearing loss between 3,000 and 6,000 hertz. If case history reveals noise exposure, always test at 3 and 6, the mid-frequencies. We're almost done here. SRT, speech reception thresholds, will be quite normal because hearing at 5, 1, and 2,000 will be good. Here, let's share the screen. Let's look at it. Okay, there. Make this bigger. What did we say about last week about SRT, the softest you could hear, those 2-syllable spondee words? Hardware, cupcake, armchair, ice cream. Remember we said last week the softest you could hear speech, those 2-syllable words, has to agree with something called the PTA, and I don't mean Parent Teachers Association, has to agree with the pure tone average thresholds at, watch my cursor, 500, 1,000, 2,000 hertz. What's the average hearing of these for each ear? 10 plus 15 plus 20, add them up, divide by 3. 15 plus 10 plus 20, add them up, divide by 3. Basically, you'll come up with something around 10 to 15 is the pure tone average. Always remember the 3 frequencies, 5, 1, and 2. The softest you could hear spondee words, your speech reception threshold should agree with your pure tone average. If it's not within plus or minus 5 dB of your pure tone average, Houston, you have a problem. Either your audiometer is out of whack, out of calibration, or you don't know what you're doing, or your client is lying. And that's one of the symptoms of a liar, is that the pure tone average will not agree with the SRT. We'll talk more about that in our last week of class. Pseudohypoacusis, people faking hearing loss. People do it for financial reasons, for psychological reasons. It's a real bummer, but people do it, okay? Anyway, noise-induced loss. What will their findings be? A high-frequency sensory neural loss. Notice again, bone conduction is similar to air conduction. And the loss will be between 3,000 to 6,000 hertz, mostly at 4. And tympanograms, type A, normal. Acoustic reflexes, normal. Okay? Speech reception thresholds will be soft, just like the pure tone average. Speech discrimination or word recognition in quiet, pretty good. Fair to decent, not bad, can't complain. Always remember, the saddest thing about noise-induced hearing loss is that it is preventable. If you can hear someone's headphones and you're not listening to the headphones, that person's going to get noise-induced loss. Okay? It's just a fact. We don't stare at the sun because we know we're going to go blind. But for some reason, society has not really figured out that excessive noise causes noise-induced hearing loss. And if you're getting a lot of noise pollution, like described, 85 dBA for 8 hours a day, following that rule of thumb, you're going to get noise-induced loss. Elderly people in Africa have better hearing than elderly people in Canada and US. The reason why is because Africa has less noise pollution. Our ears were meant to hear soft voices over the crackling of a fire and thunder claps in the distance, maybe accompanied by the roar of a lion. We were not ever meant to hear the clanging of steel on steel. Well, this has been extra special. We'll conclude our Zoom session here. I'll stop sharing. We've managed to cover presbycusis and noise-induced hearing loss. Next week, we'll finish noise-induced hearing loss, which won't take much because there's not much more to cover. We'll kind of review it a bit, and then we'll move on to finish this unit on inner ear disorders. We're moving along just right in this course. If we don't quite get done inner ear disorders next week, we'll certainly finish it off by the week after. I'd like to move on after this to retrocochlear pathology, eighth nerve pathology, which is rare, which is a red flag, and which causes unilateral sensory neural loss. Whenever you're testing someone and the sensory neural loss is only one ear, you have a red flag. Okay, you need to refer to an ENT or doctor to rule out an eighth nerve tumor, but that's mañana. So I'm happy with what we've covered so far. Again, I'll always encourage you, if you watch the Zoom session once, watch it again. Courses are normally 3 hours in length for 3 credits. These Zoom sessions are an hour. This one's been an hour and almost 10 minutes. So anyway, I'm done here. I'll stop recording now. See you next time.